Well, great. Thank you, Rahul, and thank you to T2 for putting this together and for everyone getting up bright and early to attend. So I'm sort of contorted here. We'll see how this goes. I am from the University of Pittsburgh and VA Pittsburgh. I'm an ID physician and chief of infectious diseases at the VA, as Rahul said. Here are my disclosures. So obviously everyone here is well aware of the problem with Candida as a cause of bloodstream infection and sepsis. You know, mortality rates remain unacceptably high. And you're also aware of the inadequacy of blood cultures as a gold standard diagnostic. Sensitivity is only about 50%. Moreover, turnaround time is slow. And this is important because we know that delays in initiation of appropriate antifungal therapy are associated with increased mortality for candidemia. So the T2 Candida Diagnostic Panel has been FDA cleared for the diagnosis of candidemia, and it directly tests within whole blood for Candida cells. So you have a self-contained desktop machine, the T2Dx machine. You take an EDT tube, you pop it in the machine, it lyses the Candida cells, it amplifies an ITS target, and then agglomerates that with nanoparticles and detects the nanoparticles within the self-contained instrument by T2 magnetic resonance. It is not dependent upon viable Candida cells, and it gives you reports qualitatively with three outputs, positive or negative for Candida albicans, Candida tropicalis, positive negative for Candida glabrata, Candida krusei, or Candida parapsilosis. And of course, these groupings have relevance to antifungal susceptibility testing typically. And in most centers, these species are going to account for greater than 95% of cases of invasive candidiasis. So FDA approval was largely based on data from this trial published in Clinical Infectious Diseases. Most of you are familiar with this. This is the DIRECT-1 study, multi-center study with a large number of prospectively collected blood samples at the same time of blood cultures, as well as contrived spiked blood samples for the various species that T2 detects. And what they found with this study design was sensitivity and specificity for T2 Candida of 91 and 99% respectively. And moreover, the mean time to positive result and species identification was a little over 4 hours for T2 Candida versus a little over 5 hours for blood cultures. So these are compelling data. A relative weakness of the study, however, is that there were only 6 patients who had candidemia who were enrolled in the study. So the sensitivity was largely derived from the contrived blood samples. So DIRECT-2, the results of which will be presented Saturday here at this meeting, was a multi-center study at 14 US centers, the objective of which was to determine the sensitivity of T2 Candida among patients with active candidemia. And then secondarily, to review the performance of T2 Candida and blood cultures, both in the presence and the absence of antifungal therapy. So in brief, 152 patients with proven candidemia, as documented by a diagnostic blood culture that was positive, were enrolled at the time that the blood culture was reported as positive. So typically 2 to 3 days later, people were enrolling patients and collecting simultaneously a follow-up blood culture, companion blood culture, and T2 sample. So at the same time from the same place. And the T2 Candida and companion blood culture were deemed positive if they identified a Candida species that was identified in the original diagnostic blood culture from that patient. So the primary endpoint was the clinical sensitivity of T2 Candida. T2 Candida being positive in patients who at the same time had a positive companion blood culture. And secondary endpoints included the T2 Candida performance among the entire cohort of patients who were originally identified with a positive diagnostic blood culture. And this included patients both receiving and not receiving antifungal therapy. So sort of a real-world study design with a lot of empiric and preemptive therapy. So here are the patient demographics, and it's sort of a typical candidemia cohort. You've got all the usual, suspects in terms of Candida risk factors. You'll notice that 75% of patients at the time the T2 and companion blood culture samples were collected were already on antifungal therapy. And this included, a combination of various regimens. So if you look at the microbiology in the diagnostic blood culture, again, what you'll see at many centers nowadays, albicans, parapsilosis, glabrata, most common, in fact, identical numbers of these organisms, tropicalis fourth, and then a smaller number of krusei and various combinations of species. So the primary endpoint, the clinical sensitivity, was 89%. So there were 36 patients in this cohort who had a positive companion blood culture at time of enrollment. T2 was positive in 32 of these patients. Moving on to the secondary endpoints, looking at the entire cohort of 152 patients who were originally enrolled, overall T2 positivity was 45% compared to only 24% for the companion blood culture, so significantly more sensitive for detecting Candida 2 to 3 days after an initial positive culture. And if we look at the patients who are receiving or not receiving antifungal therapy, what we see is the superior performance of the T2 Candida was realized in patients who are receiving antifungal therapy, where T2 Candida positive in half of these patients versus only 21% of patients positive by the companion blood culture. And again, highly significant. Among patients not receiving antifungal therapy, T2 Candida and companion blood cultures were equally likely to be positive. So if we look at the combined T2 Candida blood culture results, sort of in this flow chart, here's our entire cohort with a positive blood culture to begin with. T2 was positive in 45% of these patients, negative in 55%, and T2 positive blood culture positive in both in 20% of the overall cohort. Both tests, the T2 and blood culture, were negative in 52%, but the key results are here where we've got discordance. So T2 identified 37 patients as positive that were negative by the companion blood culture, and conversely, the companion blood culture only identified 4 patients who would have been missed with the negative T2. And if we look by multivariate analysis for the predictors of T2 positive companion blood culture negative results, the most significant finding was prior antifungal therapy, which was highly associated with this discordant result where T2 positive and the blood culture was negative. So if we stratify the flow chart by antifungal therapy, on the right, your right, we have the 1/4 of patients who are not receiving antifungals. And again, you can see that T2 only identified 2 patients who were missed by blood culture, whereas blood culture identified 1 patient who was missed by T2. However, among the 3/4 of patients who were already on antifungal therapy, T2 Candida identified 35 patients that were missed by blood culture, whereas blood culture only identified 3 patients who were missed by T2. So in conclusion to Direct-2, T2 Candida accurately diagnosed candidemia at the time of positive companion blood cultures. The clinical sensitivity of 89% basically corroborated the analytic sensitivity of 91% from the Direct-1 trial. T2 Candida identified patients with recent candidemia who were negative by companion blood cultures, the so-called T2 positive companion blood culture negative results. And what this reflects is the fact that T2 Candida will detect inviable, latent, or non-proliferating Candida cells that will be missed by culture. And moreover, T2 Candida was significantly more likely to be positive among that group of patients who were already receiving antifungal therapies. And I think the important clinical implication of this is that T2 Candida may identify cases of candidemia that would be missed by cultures among patients already receiving preemptive, prophylactic, or empiric antifungal therapy. So if we take Direct-1 and Direct-2 now, I think we have a pretty good sense of how T2 Candida is actually going to function in the clinic. So between the 2 studies, sensitivity is approximately 90%, specificity is approximately 98 to 99%. And the thing about candidemia is we can go in and we can identify well-described cohorts who have well-described prevalence or pretest likelihoods of candidemia. And with the positive and negative, with the sensitivity and specificity, you can now calculate anticipated positive and negative predictive values in various patient populations. And if you go through this exercise, what you'll find is basically any risk group that you might use the test in, the negative predictive value is exceptional. So even if you were taking non-prophylaxed bone marrow transplant recipients who might have a 20% pretest likelihood, the negative predictive value still remains 98%. And moreover, positive predictive values actually increase pretty rapidly once you get out of the very low-risk groups. So you see here, if you take febrile neutropenia, prior to empiric antifungal therapy, the literature would suggest about 2% of these patients will have candidemia. Your positive predictive value basically is 50%. So at some point here, the positive predictive value becomes high enough that you should probably be treating patients, even though you don't know definitively that they have disease. So based on positive and negative predictive values like this, it's now feasible to design antifungal treatment and de-escalation strategies in different patient populations that might incorporate this test result. So for example, at the University of Pittsburgh, we've got a couple of these. These are the first two we've put together. In the medical intensive care unit, we're mostly after septic shock, and Candida is going to be about 3 to 5% of these patients. So here, we're primarily exploiting the positive predictive value to get early therapy on board in patients with septic shock, and then in a smaller cohort who've already been on therapy, we're using negative results to de-escalate. Another approach is sort of the more surgical intensive care unit patients, where now your risk factors are different, and you've got various populations who are at varying degrees of risk for candidiasis, patients who've had abdominal surgery, biliary tract manipulations, and you can go through similar exercises in these various populations, and you can come up with either initiation or, more commonly in this population, de-escalation strategies making use of the negative predictive value. So we're accumulating our data, and hopefully we'll be presenting at meetings in the upcoming year. But I think what it shows is that if you're going to optimize the utility at your center, you're going to have to understand your local epidemiology, what type of disease and what patient populations you're studying in, and you're also going to have to understand your microbiology and understand that the 5 species that the test will identify are in fact the most common at your center. So where are we now? This is an important advance, I think, in the diagnosis and management of candidemia. There are a number of immediate clinical questions that are going to be require answers. And these data are actually accumulating. There are 7 posters at this meeting. I encourage you all to check them out. I'm having a little trouble advancing. I'm going to talk in the final minute about several studies, though, that are not presented at this meeting, but have been presented at other meetings and will be published shortly in the Journal of Antimicrobial Chemotherapy. And this is beautiful work out of Spain, where what they asked is if you have patients who have documented candidemia and you've started antifungal therapy, and then after therapy is started, you do serial testing with a variety of diagnostics, do any of these predict outcome? And what they found, in fact, shown here with the green pluses, these are positive T2 results after the initiation of antifungal therapy. And these are patients who had complicated candidemia. They either died or they developed end-organ complications. And what they found is, uniquely among these tests, T2 Candida predicted the poor outcome group. And here are within 1 week, if you had a positive T2 Candida, this is sensitivity, specificity, positive and negative predictive values for a poor outcome. So T2 Candida not only has diagnostic utility, but its greater utility may actually be in a prognostic realm. The same group in Spain, Patricia Munoz and her group out of Madrid, also looked at empiric therapy. And similarly, T2 Candida in patients who are started empirically, if after treatment is started, remains positive, has an odds ratio of 26 for predicting pure outcome, whereas other tests, including beta-glucan, do not have this utility. Other studies out of the US have asked questions like, can T2 shorten time to definitive antifungal therapy and duration of empiric therapy? And in both cases, this hospital group, hospital network, was able to show that a positive T2 Candida shortened the mean time to definitive antifungal therapy from 34 to, that should be 6 hours compared to blood culture. And among empiric treatment, they were able to reduce the duration from 6 days to 2 days using negative results. And in this hospital system, that was associated with an estimate just on antifungal costs, mean savings of $280 per patient tested. So these are early reports, but I think it shows where the field is going. And that is that, I think with Direct 1 and Direct 2, we've now established what the basic performance characteristics of the test are. And where we've gone to now is defining how we can use the test as a prognostic and patient management tool. And I think along those lines, it's very important that people who are accumulating real-world experience share that with the community so that we can learn together how to use this most effectively and efficiently. So with that, I'll hand it off to Glenn, and I'll be happy to answer any questions. I'll be leaving the meeting tomorrow, but people are free to email me or contact me at any time electronically, and we can talk about some of our experience at Pitt. Thank you very much.